Thanks everyone for coming. Thanks for coming to Spine Conference. Today's Spine Conference is going to be on opium and the surgeon. So why why go over this topic? Basically, some diseases cause pain, and some diseases can be treated with surgeries, and the surgeries can cause pain as well. And opiates decrease the pain. So surgeons prescribe opiates. And what are opiates? So that's basically why I want to go over this topic. So opiates come from the poppy plant. The poppy plant geographically originates in the Indochina area. We'll get into that too. And the active ingredients are morphine and codeine. And currently the main producers, and we're going to go over this as well, is Afghanistan and India. Although new places of production are Mexico and Colombia. It has to be grown in a kind of a dry, warm part of the world. The number one consumers of opium is Americans. And just so you understand the price of opium, wholesale is $3,000 per kilogram, and retail is $16,000 per kilogram. And just to get an idea, gold is $36,000 per kilogram. So it's about a little more than a third the price of gold, opium is. So opium is also found in the body. So it's basically, there was a book I just recently listened to or read called Opium, Flowers in the Blood. And we basically have this opium. Opium comes from the poppy plant, which is a flower, but we also have this substance naturally in our entire bodies, and they're called endorphins. And they're a group of proteins that have pain-relieving properties that are naturally found in the brain, and they're called, the other subtypes are enkephalins, beta endorphins, dynorphins, and they were discovered in the 1970s by Roger Gilliman, probably saying that wrong. And their beta endorphin is found entirely in the pituitary gland, and they have analgesic effects. They have some relation to appetite control, sex hormones, and they're also associated with pleasure centers of the brain. So what do opioids do? So I think this is kind of important to understand where opium affects. So in the brain, in the cortex, it gives us analgesia, which is obvious. It's a pain reliever. It also can give us euphoria, which is different from pain relief. It's a feeling of well-being. It also makes you sleepy. It's a central nervous depressor, and also can cause addiction. In the hypothalamus and pituitary, it decreases testosterone. In the brainstem, it decreases our respiratory rate. So if we give too much, people can stop breathing. It causes nausea, vomiting, meiosis. In the spinal cord, it gives analgesia. So it gives pain relief centrally, but also in the spinal cord, it gives analgesia. In the gastrointestinal tract, it causes gastroparesis and it decreases peristalsis. So it's very helpful for cases of diarrhea. But it's also bad in the sense that it gives people constipation. In the urogenital tract, it increases ureteral tone, detressor tone, and urinary sphincter tone. So again, in our patients, it's a big problem because we give them a lot of morphine and they have urinary retention post-op. And that's why, Aaron, we always give a Foley to patients, because we have that constant problem with urinary retention. And in the cardiovascular system, it decreases peripheral resistance and decreases your heart rate. So we see this, when we see this in the elderly, right? They get hypotensive and bradycardic. So that's kind of like a general review. Do you want to, anything, Jeff, you want to add to that? Okay. So where did it start? I mean, opium has been around since man has been around. So the first descriptions are basically the first descriptions we have of man. So it probably predates even the Sumerians. But the Sumerians were the earliest known civilization in Mesopotamia between the Tigris and the Euphrates rivers. So basically, as long as man has been around, opium has been around, which is kind of amazing. So it's a drug that we probably discovered, mankind probably discovered when they were cavemen or something. They probably started biting on the plant, because the first noted description was in the Sumerian culture, which was our first civilization. And this shows you just where Mesopotamia is. It's currently Iraq, Iran area. where Baghdad is, between the two rivers, the Euphrates and the Tigris River. So the earliest reference to opium is around 3400 BC, and this is super, super ancient in Mesopotamia. And the Sumerians referred it to as the Hul-Jil, or the joy plant. And they passed it to the Assyrians, who then passed it to the Egyptians. And the Egyptians cultivated opium as well. They had famous poppy fields, and the trade flourished in Egypt. Doug, good morning. Come on in. Today's talk's on opium. We're going over the history right now. So the trade, this is the trade routes around 1300. The Phoenicians, can you see my arrow? The Phoenicians were on the right there, on the coast near where Lebanon is currently. And the Phoenicians and the Cypriots and the Minoans used to trade opium back and forth across the Mediterranean Sea to Carthage, to Sardinia, to Rome. And this is proven by, you see there on the left, there's a vase that's exactly in the shape of an opium plant. And on the right is the Minoan seal and the Minoan god, and she's got poppies, the opium plant, on her head. So they were basically like part of their religion, opium. And opium was around when at the time of the Trojan War. So they actually had the Cypriots had very specialized knives, surgical quality knives, just to harvest opium. And they would cultivate it, trade it, and they would also smoke it at that time. So we're talking like 1100 BC. This is like really ancient. Like the Trojan War was really ancient. Hippocrates, which is now around 460 BC, described opium as a very useful narcotic and also a styptic. And I guess he used it to stop bleeding for some reason. And he also treated the disease of women and epidemics. So why women? I have no idea. Aaron, do you have any idea why women would like opium? Now, in 330 BC, so opium started in Mesopotamia, the first noted description of it, but its roots are in Europe, not in Asia, which is where most of it's grown now. And Alexander the Great brought it to Persia and India. And then during the times of the ancient Greeks, it was a very powerful pain reliever. It was also used for sleep and for problems of the bowel. And also the pleasurable effects were noted by these people too, and they would trade it somewhat to China. So between 200 BC and 300 BC is the time of the Silk Road. And basically there was a lot of trade between China, the Middle East, and Europe. And opium was a very big product. Now, what's interesting about opium is that it wasn't described in the Middle Ages, but nothing was described in the Middle Ages. That's why they call it the Dark Ages. But the problem with opium is it's very difficult to cultivate, harvest, and produce in mass quantities. So it was never produced in mass quantities. In fact, if you look at the literature from the Muslim culture, they more discussed hashish as a drug a problem drug for addiction. They didn't really discuss much of opium, and I think most people think it's because there was just not that much opium around. It wasn't mass produced. The time that it was started to be mass produced was around the 17th and 18th century, when the Europeans developed mass production techniques. And this just shows a factory in India. So the majority of the mass production of opium was it was grown in India, which is a good place to grow it, and also they would mass produce it in there. And it wasn't the Indians who were doing it, the Indian people, but rather Europeans gave them their factory techniques, and they were just doing it there. Now, so the history of opium has a lot to do with tea, because British loved tea, and China had a lot of tea. So what happened is there was a lot of trade between Britain and China with tea and opium. So the way it worked is the East India Company was a royal chartered company in the 1600s, and it had a monopoly on the trade of opium to India and Asia, and they had a monopoly, I think, on tea as well. So what they would do is they would cultivate the opium in India and then ship it to China on the boats, where they would sell it in China, and they would get tea back and bring the tea back to Britain. But the problem was opium was destroying China. So the emperors made it illegal, and they said, no more opium, you're destroying us. But the British and the French wanted to stay legal because it's extremely lucrative, and they wanted the tea. So what happened is there was a conflict, and in fact there were two wars, the Opium Wars in the 1800s. The first one was 1839, and the second one was 1856. The first one was just the British, and the second one was British and France. And the British and the French won a very decisive victory, and then the trade agreement was horrible for the Chinese. And I think since then it's been sort of a painful subject for the Chinese. So the opium trade continued into China, basically just causing severe problems there. When the Chinese migrated to the United States, they brought this opiate addiction with them. So this is an opium den in San Francisco, where because it's close to China, there were a lot of there were opium dens in San Francisco and Chinatown, and it started becoming a problem in the United States. And the Harrison Narcotic Act was in 1914, and it basically regulated and taxed the production and importation of opium and coca products. Before that, it was legal, and people usually smoked it and they ate it. So, any questions so far about opium? So I kind of found it interesting. Like, where does opium come from, and how did it evolve? And this is a picture of Friedrich Wilhelm Adam Sertiner, who isolated morphine. So morphine was isolated from opium in 1804, and his drug, he named it after Morpheus, which was the Roman god of dreams, who was described by Ovid. And after isolating it, Merck sold it in Germany in 1827 from just one shop, and that was sort of the beginning of a massive pharmaceutical empire for Merck in Germany. Around the mid-19th centuries, people started injecting morphine through syringes. So basically, morphine comes from the poppy seed, which you can buy. It's a flavor, and they put it on bagels, things like that, and cakes. And opium begins, you plant it with the seeds, and the opium is usually grown in the world by poor farmers, and usually in small farms. And most of it is grown, the illicit growth is, most of it's grown basically from Turkey all the way to Burma, which is just east of India, in that entire area. So Turkey, Iran, Afghanistan, Pakistan, India, and Burma. In that area, it's mostly because of the climate. Now, opium cultivation in Afghanistan decreased maybe 3 or 4 years ago, and that was in part by the United States. That we had a $7.5 billion program to stop opium growth in Afghanistan, but it's failed. And as you guys know, we're getting out of Afghanistan. Like December 2014, we should be completely out. And the opium now is, and the American troops now are just in Kabul, which is in the northeast, and also in the western part of Afghanistan. But in the west and the south, in the south, mostly in the south, in the Helmand and the Kandahar provinces, that's where all the opium is being grown currently in Afghanistan. And I think the estimate is 75% of all illicit opium production is in Afghanistan. It's very lucrative for them, and 90% of the legal opiate growth is in India. So the legal from the pharmaceutical industry. As far as how much is made, in 2011 there were 440 tons of morphine, 381 tons of codeine, 43 tons of hydrocodone, 32 tons of methadone. And for oxycodone, most of it's in the United States. 82% of all oxycodone is eaten in the United States. So those numbers, like 440 tons of morphine, to give you an idea, an elephant weighs 4 tons. So it's the size. So the world creates 110 elephants worth of morphine. You think that's a lot or a little? Like, I don't know. The world's big, I guess. So morphine is the first drug we'll go over. Morphine is the gold standard for opium. It's a natural substance. It acts on the central nervous system. Um, Heroin's a precursor for morphine. Morphine and heroin are the most addictive of the opiates. You get both psychologically and physically dependent on it. You develop a tolerance to it. It gives analgesia, sedation, euphoria, physical dependence, respiratory depression. The peak levels when you give it intravenously or subcutaneously is in 20 minutes, and if you eat it PO, it's 30 minutes. So it's pretty fast onset, but not super fast. I think morphine's faster than 20 minutes. I think it's more like 5. I mean, I know I had appendicitis, and they gave me a shot of morphine, and within 5 minutes I felt pain relief. And with patients, don't you think it's a little faster than 20 minutes?
For IV morphine?
Yeah.
Oh, it's
Yeah.
fast.
It's much faster. It's metabolized in the liver, and it's controlled by like we discussed, the Harrison Narcotic Act of 1914. So this is a tablet of codeine. So codeine is less potent than morphine, has less dependency issues and withdrawal symptoms. It was found in 1832 in France by Pierre Rubequet, and it's the most widely used opiate in the entire world. And in fact, in some countries, you can get it without a prescription in combinations with other medications like Tylenol. For example, in Australia, you can buy it in a 15 milligram tablet over the counter. New Zealand, Poland, Romania, and Costa Rica, a 12.8 milligram tablet. And also in Canada, you can get it in an 8 milligram tablet. And I remember a Canadian woman told me this. She asked me for codeine, and I said, no, I don't have any indications to give you codeine. And she said, well, where I live in Canada, we can just go buy it. I don't need your prescription. It's kind of interesting. I didn't know that. So heroin is another opiate. Heroin is also called diacetylmorphine. It was discovered in 1874, so maybe 50 years after morphine. And it was commercially available by Bayer, the German company, in 1898. And it's about 1.5 to 2 times more potent than morphine. It's very lipid soluble, and it crosses the blood-brain barrier very quickly. So that's what gives you the high from morphine, is how fast it goes to the blood-brain barrier. And apparently, heroin's the fastest, and that's why it's the drug of choice for people who want to get high. And it overtook morphine for the drug of choice for abuse once it became available in 1874. And it was very powerful. And the heroin trafficking and trade routes are very similar to opium. It starts in the Mesopotamia area in India, and it floats to the Western countries. So what's hydrocodone? Hydrocodone is also called dihydrocodeine, and it's an opioid from codeine. It was first synthesized in Germany in 1920, so kind of recent. Hydrocodone is 6 times stronger than codeine, and that's where the word Vicodin comes from, because VI is the Roman numerals for 6. So it's 6 times stronger than codeine. It's 50% as potent as morphine for analgesia, and the serum half-life is 3.5 hours. So it lasts kind of a long time, but takes some time to build up. And it's metabolized by the liver. It decreases testosterone. So effects are very similar to morphine: drowsiness, dizziness, lightheadedness, anxiety. Sometimes it can give a rash. It can cause nausea, vomiting, difficulty urinating. Again, we get a lot with that with our patients. Constipation, which is a big problem with opiates. Now, Vicodin is a very common hydrocodone that's prescribed. Just so you understand how many prescriptions are given in the United States, just in 2012 there were 259 million prescriptions for opiates. So basically every single adult in America was prescribed 1 bottle of opiate pills. Vicodin in 2010 was the most common, 131 million prescriptions. The street price for Vicodin is $2, and in 2014, this year, the DEA lifted it a level from a Schedule 3 to a Schedule 2. So the basic change is you can't call it in, and you can only refill it for a 90-day supply. So it's basically the same schedule now as oxycodone, right? I don't think it's any different than oxycodone. It's totally the same. Now, opiate intake or painkiller prescriptions, this is legal painkiller prescriptions, varies in the United States very, very widely. So this is a 2013 graph. On the left is the lowest states, the lowest input states: New Jersey, New York, Hawaii, California, Minnesota. And on the right is the highest states. This is number of painkiller prescriptions per 100 people. So in Tennessee, Kentucky, it's like 143, 128 prescriptions per 100 people. So more than one bottle, like 1.5 bottles per person per year. Maryland, we're right in the middle. We currently are 74 prescriptions per 100 people per year. So 3 out of 4 people in Maryland get a prescription bottle a year of painkillers. But laws change this. For example, in New York in 2012, prescribers had to check the state's prescription drug monitoring program before prescribing the painkillers. So basically, you have to go online and look the person up and get basically authorization to give the prescription. And that decreased prescriptions by 75%. And I know a lot of my friends who are doctors, they just don't give out opiates anymore. They're like, well, I don't do that. Same in Florida, the pain clinics were regulated, and they had a 50% drop in overdose deaths. Also, Tennessee, they require prescribers to check the state's prescription drug monitoring program, same as New York, and there was a 36% drop in seeing multiple prescribers for pain medications. And these are the states, the darker states are the ones that have the highest prescriptions per person. So it's kind of interesting. It's like this, basically the Southwest mostly, but then into the Midwest too, in Kentucky, West Virginia, Ohio, Indiana. Maryland's kind of middle of the road. So any questions or comments about that? About oxycodone is another prescription I prescribe all the time. OxyContin is the Purdue slow release oxycodone. So it's a very similar drug, just slow release. Oxycodone was synthesized in Germany in 1916, and it was made to replace heroin and morphine, and they were hoping that, I think, to decrease the dependency issues. Patients get withdrawal from it. The peak plasma is in an hour, 10 minutes onset. It's 50% weaker than morphine. It does have an abuse potential for snorting, unlike morphine and heroin, which must be injected. There's less stigma involved with oxycodone than heroin and morphine, and the street price is around $1 a milligram. So it's a $5 for a 5 milligram pill, oxycodone. And the side effects are very similar to hydrocodone. The next drug is Dilaudid, which was discovered in Germany in 1924, and it's 3 to 4 times more potent than morphine. There's less dependency issues in morphine. It's very powerful for euphoria, very rapid onset, withdrawals accelerated, and it's equivalent to 8 to 1 for morphine. And we usually use Dilaudid. Do you use Dilaudid at all, Jeff? We use Dilaudid in PCA pumps for patients that require a lot of medication. It's usually just because it's there's a dose, there's like a quantity issue. You like they run out of the morphine pump quicker than Dilaudid. So methadone is another synthetic opiate. It was first produced in 1930 in Germany, and it was initially made so that it's not as addictive as morphine. It's inexpensive compared to the other medications. The duration is much longer, and the onset's much longer, 48 hours, and the half-life is somewhere between 8 to 59 hours. So the half-life is very long. Sometimes the full analgesic effects are not attained until 3 to 5 days after starting, so it's kind of like a long-acting dose. Do you have anything to add, Jeff, to methadone at all?
Methadone is probably responsible for the majority of opioid overdoses in the United States.
Methadone, really?
Yeah. It's at least the deaths caused by opioid overdose because of the cumulative effect. It takes a long time to reach peak effect. Patients have to be titrated up slowly.
So
And-
people take it maybe to get a high, and they don't realize the onset's in like 24 hours, and
Yeah.
once the onset happens, they stop breathing.
Well, also, if you continue to take it cumulatively, it does accumulate in the body. So whenever you're titrating someone on methadone, don't make dosage changes for a week or two at a time as you slowly escalate the dose. Otherwise, they could end up 3-4 days after you make the change, they end up with
Respiratory depression.
And it has a fairly good street value. It's a good drug because it has some anti-neuropathic effect also, because it works on NMDA receptors also instead of just mu receptors. So it's a good drug, but it has a lot of social stigma, and it's a little dangerous.
Okay.
It also causes a QT prolongation. So patients that are predisposed to QTC prolongation or cardiac arrhythmias should be evaluated with the EKG before it's used.
Okay. So the Controlled Substance Act in 1970 created these stratifications for opiates, and the only change from this is hydrocodone is a 2 now. So the class 2s are cocaine, Ritalin, oxycodone, morphine, methadone, fentanyl, Dilaudid, Nucynta, and now hydrocodone. So withdrawal from morphine in around 6 to 14 hours after cessation of morphine, the patients get drug craving, anxiety, irritability. 14 to 18 hours, they have heavy perspiration, mild depression, crying, runny nose, dysphoria. 16 to 24 hours, rhinorrhea, dilated pupils, muscle twitching, where you get the term kick the habit because their muscles twitch. Hot flashes, cold flashes, aches, myalgias, intestinal cramping. 24 to 36 hours, severe cramping, involuntary leg movements, loose stools, diarrhea, insomnia, hypertension, slight fever, tachycardia. And from 36 to 72 hours, a day and a half to 3 days, they have vomiting, liquid diarrhea, and the total withdrawal is around 7 to 10 days. And they also get psychological issues of severe depression, anxiety, insomnia, mood swings, amnesia, low self-esteem, confusion, paranoia. Sounds terrible. So, do you have anything to add to the withdrawal?
I mean, I've never experienced it, but it's supposedly awful.
Yeah.
I've seen patients that have had it.
Yeah, I've seen many patients with it. So basically, when I see patients and tell them stop, I basically say you'll have the flu for a week, which I think is. Do you say anything else, or how do you describe it?
We have an extensive conversation about what can happen. If someone's been on chronic opioids for some time and we're going to terminate opioid therapy for one reason or another, we generally either wean them off over a period of time, which is a controlled program.
What's your ballpark period of time that you use?
It depends on the person. I've seen people that have taken weeks to do it easily. Some people, it's very simple for them. But I've seen post-surgical patients that have been on, OxyContin or whatever for just a couple of weeks, and then they thought they could just stop it, and they end up in the ER.
Yeah. But 2 or 3 weeks, you think is kind of a slow wean?
Yeah. I think, this is not hard and fast, but I think, a 10 to 15% decrease every, 2 days or something like that. You should
Is that a rule of thumb?
Yeah, that's reasonable. They're probably not going to like it, but
Right.
it's not going to be, they're not going to be...
like a horrible flu, or like you have gastroenteritis.
The other alternative is you just immediately refer the patient to a addiction specialist, and they can put them on a partial, like a buprenorphine, Suboxone, and they can immediately discontinue the opioids and just use the Suboxone and taper off that. It's a much more pleasant option, but there's a social stigma there also.
Okay, so as far as drug overdoses, these are statistics from 2010. In the United States, 26,000 people fell to their death, 31,000 died from guns, 33,000 people died in car accidents, and drug overdoses were 38,000. So more than any of those groups, which is kind of an amazing statistic. And our car accidents have gone down tremendously. When I was a resident in 1995, it was, because I looked it up, it was 50,000 people. So we, as a society, we've done much better on car accidents, but much worse now on drug overdoses, which I mean I don't know, it's got nothing to do with it. So as far as number of deaths related to prescription opiates, not illicit drugs, it's 16,000 deaths a year in 2010. And the deaths have been going up. This is a graph from 99 to 2009. And the deaths basically track the prescriptions that are prescribed. So the more medications we prescribe, the more people die from overdoses. And that's what stimulated the government to change the hydrocodone from 3 to 2, I believe. And the supply and the demand of opiates is increasing. So you can look at a graph from 2008 to 2013 is definitely increasing a lot. Especially in 2013, things have increased tremendously. I'm not sure if that has anything to do with the fact that we pulled out of Afghanistan, or if it's more of a social issue in our country. I have no idea. So basically, it's a supply and demand thing. Is it our demand's going up? Is the supplies going up? It's hard to say. So just in general, the opium is used for pain, and only individuals feel the pain. And like I've said many times, as physicians, we always believe emotions if someone's angry, but sometimes we don't believe people are in pain. So I always say this to myself: is you have to believe every single person that says they're in pain, that they are in pain. The problem that a lot of people have is the emotion that's associated with the pain. So like we discussed, some pain people feel feels good, like in the sadomasochistic people, when they feel pain, it's actually a sexual turn on, and it helps them. It makes them feel good. My point only is that it's not only the pain that people feel, but the emotion that's associated with the pain. So this is just one more. This is global consumption of opiates in billions, and it's definitely tracking up. The drug supply is dramatically increasing, and especially increasing is the amphetamine type drugs. You see, that's the top line there, like methamphetamine. As far as proportions of people that take non-pharmaceutical illicit drugs in the U.S., you see the U.S. men are the highest. It's like almost 20% at one point in their lives, like 1 in 5. Australia is close behind. Women not so much actually in the United States. It's kind of interesting. This is from this data is from the United Nations. That every year they put out a statement on the opiates and drug use in the world. And this I found interesting is the estimated disability adjusted life years of disability or early deaths from drugs. And the drug that has the most disability is opiates. So I'm not sure if that's from death or from just disability, but it's much higher than all the other illegal drugs like cannabis, amphetamines, codeine. So opiates, people either die or they're basically disabled. So you can imagine, these people here are in a drug house in New York. They're not being productive at all, and basically their lives are destroyed. The other thing is with opiates is people develop tolerance over time, which is a serious problem. You can, I just tell patients, just with alcohol, you become tolerant after drinking a lot. It takes 5 or 6 beers to get drunk, when it used to take just 1 beer to get drunk when you first started drinking. And the other problem that I see a lot in patients is opioid-induced hyperalgesia, where they get paradoxical allodynia, so everything hurts. So despite being on massive opiates, they're in massive pain. So I try to have this discussion with people that cessation of the opiates will actually resolve the pain, which is like, doesn't make any sense. Do you ever discuss this at all? Or?
All the time. I tell them all the time.
Do you have any tricks or any things that helps you have patients understand it, or?
I use a lot of analogies to try and help people understand, but in the end, it just people are afraid of the pain, and they know the medicine, they think it's helping them, so it's very difficult to convince them that the medicine is counterproductive.
Both physical and psychological dependence. So to stop it, it's you have to tell them they have to go through a week or 2 of horrible withdrawal. It's really hard.
Yeah, I'm not sure that necessarily you need to completely, discontinue opioids to sort of back off of this hyperalgesia, but you have to certainly decrease the dosage. And you know, I see patients all the time that are on inappropriate dosages, and we have this discussion, and you know, half the time they want to, you know, they want to feel better, so they're willing to do what I tell them, and half the time they're just not willing.
Yeah.
Because they're, you know, they're basically afraid of the consequences.
Right. Which is, I think, quite natural.
Yeah.
To be afraid. I mean, if someone told you you're going to have a gastroenteritis and the flu for a week, you would not be happy about that week.
No.
I mean, you would not look forward to it at all.
Oh, yeah.
That's one of the most miserable feelings in the world. Okay. So
There's also a, you know, a subset of patients that are taking opiates for pain control, but in reality, the opiate may not be helping their pain very much, but what they're really taking it for is to prevent withdrawal.
right.
And there's the anxiety of the, you know, decreasing opiate dose that is the drive for them to take it again.
Right. Well, just avoidance of withdrawal, basically, and the pain is the same.
Right.
So
But we have
that's
lots of patients where we've discontinued opioids, you know, through various ways, and they're much happier now that they're off the medicine.
the high doses.
Yeah, I've
Yeah.
had people tell me, you know, I take, you know, 1/4 as much medicine, but my pain is exactly the same as it was.
Right.
You know, as when I was taking the high dose, and
I've noticed that
but
too.
they're much more functional. They have, you know, less cognitive impairment, less side effects. They, you know, they enjoy life more. They,
Yeah.
So.
Yeah, and also the medications work. I mean, the pain relievers do give pain relief. And in the high dose management, I don't think it gives pain relief
No.
at all.
I don't think so. Yeah. Very few.
And then they're stuck. They're stuck in this very bad place where they have both the pain and this massive opiate dependency issue.
Yep. It's very complicated.
That's all I have today. So, any comments or questions?
Are you on internet access?
I could turn it off. Can we turn it off?
No. Do you have internet access?
Yeah.
Oh, yeah. I saw a great video last week. It was about placebo, and it was like a 2-minute video. But it was phenomenal. If you get a chance, you should look at it. You know, it was just like sort of to this music, and it's like, you know, a big pill works better than a little pill. 2 pills work better than 1 pill twice a day. A big shiny pill works better than a dull pill. A pill with a brand name on it works better than a generic pill. They put women on placebo for 5 years, and then they took them off of it. 40% of the women had withdrawal.
What's this video called?
Just Google placebo.
Placebo. Anything else?
Placebo, and then it's the video. You'll see it'll come up the video, and it was just phenomenal. You know, brightly foil wrapped medicine works much better than, you know, something else.
Huh.
And in, you know, blue pills work better for taking you down, and red pills work better for taking you up. And in Germany, placebo works great for hypertension, but it doesn't work in any of the other European countries. But, you know, but something else works in all the other countries and doesn't work in I swear it was like a 2 or 3 minute.
I have to see this. Yeah,
Just
it's
Google
fascinating.
placebo, the video.
I will.
It was like a little British or Australian thing. It was just.
That's interesting.
I'm not sure if it's so applicable, but it was so informative.
It's interesting. Yeah. All right. Great. Any other questions or comments? All right. Thanks, everybody.